Hazel Squires, who's a professor in health-related decision modelling. She's undertaken the led modelling projects for NICE, the Department of Health, NHS Cancer Screening Programme, and the pharmaceutical industry to inform policy decisions. A large part of that work has been around public health interventions in cancer screening, diagnosis and treatment. Hazel set up a framework to help modellers develop the structure of public health economic models as part of an NIHR Doctoral Research Fellowship, and she's finishing an NIHR Advanced Fellowship exploring methods for incorporating behaviour into health economic models of public health interventions. She leads an advanced simulation short course and contributes to teaching and PhD supervision.
Thank you. Hello. Yeah. So this is kind of two parts, I suppose. I'm going to present a toolbox, which we've called the PHEM-B toolbox, for incorporating the influences on behaviour within public health economic models. And this came about because, I'm not sure how many people are familiar with health economic modelling in the room, but it tends to have the methods tend to have originated from modelling clinical interventions, where we might use a cohort type of model, where we use kind of average transition probabilities between different health states, and estimate long-term outcomes of what is happening at the moment versus a new technology or a new intervention. And we look at kind of all the costs associated with that and all of the outcomes, and then look at the difference between the two. And I started then looking at some public health interventions and discovered this was a much more complex problem. And so one of the things I've done is to provide kind of guidance for modelers for developing the structure of models, which speaks to the talk before about kind of thinking about a bit more systematically what is in a model. And then this work is about incorporating the influences on behaviour, so drawing on behavioural science, because we kind of often get into disciplinary silos, where we kind of do our own thing, but actually there's lots of research in behavioural science that could inform these models. So that was the idea of this. So it was a big multidisciplinary collaboration between, I've got all of the co-authors on here, so we had kind of quite a large group of people, which covered behavioural science, behavioural economics, statistics, econometrics, health economics, complexity science, people that have expertise in geographical information systems, social networks, and health psychology. So we kind of tried to get lots of different expertise in the room to help develop this. I'm also, the kind of second part is a smoking cessation case study, which was actually developed with different people, which I'll go on to. It's a collaboration between UCL and University of Sheffield. And I should say the study is funded by the NIHR and Cancer Research UK. So this talk will cover why it's important to consider the influences on behaviour within health economic modelling of public health interventions, the methods for the development of the PHEM-B toolbox, a presentation of the PHEM-B toolbox and recommendations for further research, as well as the smoking cessation example. So the effectiveness of public health interventions is dependent upon human behaviour, and behaviour is complex and multifaceted and shaped by many influences which change over time. In some health economic models of public health interventions, only biological risk factors for disease, like BMI, are incorporated. In others, behavioural risk factors like smoking are included, but the influences upon these behaviours are not explicitly considered. So you might have a smoking model with some transitions where you might be a non-smoker, you might start smoking, you might then quit, you might then relapse and start smoking again. And so you'd have probabilities between those states and then health outcomes and costs associated with those states over the long term. But there wouldn't be any sort of understanding of the influences on why people smoke. So this is just a hypothetical example which shows the importance of assumptions beyond study follow-up. So this is an example with BMI, where we have the study period is in green. We have a year's worth of study data. And in the usual care arm, BMI increases slightly. And in the intervention arm, which is in blue, the BMI decreases. So it's been successful in the study period, but the study period is only a year. And in health economic modelling, we're expected to model the difference between usual care and the intervention over, generally when we're talking about things that might affect outcomes over the lifetime of a patient, we're then expected to model the lifetime of a set of patients or people in the population so that we can look at the complete differences between usual care and the intervention. This is a simplified example because sometimes we might be looking at 3 different interventions that we're comparing with usual care. But in this case, I'm just saying that there's one. And so having more than one adds more kind of uncertainty and difficulty in there. And what we tend to do after the study period is we'll make some alternative predictions, which might be based on, which is typically based on limited or no evidence or theory. So in the usual care arm, you'll see the dotted lines are the assumptions in the model. And we've just said, let's assume it carries on as it had done in the study period. And then for the intervention, we say, okay, let's assume one of the assumptions might be that it returns this blue dotted line here, that it returns to what it would have been in the usual care arm within a year after the study. And then we might have other assumptions which say let's assume that the kind of effectiveness of the intervention remains for the following 5 years and then returns to what it would have been. And so there's various different assumptions that typically are made. But as I said, it's not generally based on much evidence because we don't know what happens. But our policy decisions are based on the difference in outcomes between usual care and the intervention. And you can see, depending on which of these you pick, and indeed what you assume here as well, the area between the two is quite different. And so it would be good to kind of understand a little bit more about the kind of influences on behaviours so that we can understand the mechanisms of action of the interventions, so we can understand what might be the most appropriate assumptions over the longer term. And this is particularly important when we are looking at different interventions that might have different mechanisms of action, because we tend to assume the same thing for all of the interventions that we're assessing. So we might say, okay, let's assume it returns to what it would have been after a year, but some interventions might be better at making the behaviour change, but then not maintaining it, whereas others might be better at producing maintenance of that behaviour. And so it might be more appropriate to have different assumptions according to the different interventions, dependent upon how they work. But that's not really done at the moment. So sorry if this is a bit small on the screen, hopefully you can read it. Sorry, actually, I was going to say one other thing here, based on the comment that was raised earlier about uncertainty. So what we often do is we might put all of these assumptions in and say, you know, it could be any of these. There's uncertainty, and we've got these different scenario analyses that show what would happen for these. But ultimately, policymakers want kind of a point estimate, and they'll use whatever you say might be the best guess of the estimate, but that might not be any more informed than any of the others. So we kind of want to make more informed predictions, really. So this is a diagram of what is, so in the dark grey of this diagram, it's what's traditionally included within health economic models. So we'll have some sort of a policy or policies, which might have some, and some patients or people within the population which have inherent characteristics. So for example, age, sex, ethnicity, and socioeconomic status and education. And then we'll have these linking to modifiable biological risk factors like BMI. And then these might link to a set of diseases and long-term conditions. So that might be things like diabetes, CVD, cancers, osteoarthritis, mental illness. And then these will each be associated with costs, morbidity and mortality over time. And we might include the thing that is kind of between the dark grey and the light grey that is sometimes included is individual health related behaviours. So some models do include this. So, for example, smoking models will include the smoking behaviour. But we have a diabetes model that just uses BMI and doesn't include the behaviours like that might lead to that. But what we often don't include is the things in the light grey. So we often don't include the psychological mechanisms of action like self-efficacy or habits. And we also don't often include the community and population behaviours and social norms, and how these might interact through social networks. We also often don't include the commercial determinants of health, the stage in the life course, and the environmental context and resources, which might all affect the health-related behaviours, which might affect these outcomes. So we wanted to draw on behavioural science to understand how we might be able to incorporate this within health economic models. Now, theory is increasingly being used to develop public health interventions, and any theory that is used to develop the interventions is generally ignored when they're evaluated. But to predict the long-term effectiveness of interventions, it's important to understand the precise content and context of the interventions. So in order to develop the PHEM-B toolbox, which was initially designed to help health economic modelers to develop these models, but actually when we got people together, it became very clear that it was kind of a two-way thing, that there's also a set of things in behavioural science that challenges that could be addressed by this collaborative effort. So it wasn't just that behavioural scientists are helping modelers do things, it worked kind of both ways. And so we did a literature review of existing methods incorporating health-related behaviour within simulation models across disciplines to explore what methods could be used within health economic models. And then we developed a draft methods toolbox developed by the core team. So this was me and 4 other people from different disciplines, using the results of the literature review and 2 key case studies, which between us we'd developed previously, and we kind of thought through how we could use the toolbox within these existing case studies. And then the core group was augmented by a wider group that covered a broad range of multidisciplinary expertise. And we had a one-day in-person workshop with all 20 co-authors in 2023 to develop the toolbox further. We discussed how behavioural and social science can inform and be informed by health economic models, the general structure of the paper, the potential barriers to the methods being used, and an agenda for future research. Collaboratively and iteratively, we developed improved versions of the toolbox until qualitative agreement was reached between all authors. And the resulting toolbox is very different to the original draft. So this wasn't a case of like just ticking the boxes and getting some people and putting the names on the paper. We like from the first draft of it, it really did evolve and change an awful lot. And it was a truly multidisciplinary collaborative effort. And we have a paper of the review that's been published. The PHEM-B toolbox, if you can kind of have a look at it if you use this code if you want to, but I'm just going to kind of go through. There's a paper on this, but we also alongside it developed a website to make it more accessible. So we use behavioural science techniques to think about how we could also get modelers to use the toolbox, because we thought that there might be some barriers to people using it. And so one of the things was to kind of make it accessible. So it consists of a decision framework. I should start from home really. It consists of a decision framework to help choose appropriate methods and a description of the methods. And there's some background information, but like I've talked you through here. And then the decision framework gives you a set of methods and decisions about why you might want to use those methods. And it might be that it suggests using several methods, they're not mutually exclusive. So, for example, it might be appropriate to use a combination of agent-based modelling and econometric analyses. So it's split into 2 parts. So the first part, make that a little bit bigger, the first part is about understanding the problem and choosing the intervention and describing the intervention, sorry. And so there's 4 steps to this, which we're suggesting should always be considered if it's feasible within the process. So the first is collaboration between health economic modellers and behavioural and social scientists throughout, ideally throughout intervention development and evaluation. So often we like health economics gets put on to the end, so all the data's been collected, we've got some and we kind of, the policymaker wants to make a decision about what should be done, and we kind of have to make do with whatever whatever data we have. So ideally there'd be kind of more of a collaboration earlier on so that we can input into what data would be useful. But even if that isn't possible, it makes sense to collaborate to kind of bring behavioural science into the modelling effort. Reviewing the literature for the behavioural theories used to develop the interventions. As I said, there's a lot, many interventions have been developed now using behavioural theories. We tend to ignore that when we evaluate them, so it's important to kind of understand that and be able to potentially incorporate that into the model. To understand the problem in behavioural terms and identify the influences on behaviour. And then we propose using a behaviour change intervention ontology. So ontologies can be used to kind of put, so that so in terms of the intervention, that it's clear what intervention is being evaluated. Sometimes when we're developing a model on a specific intervention, we might review the literature on the effectiveness of that intervention, and we'll have like 6 different studies, and they'll all be like, they'll all say that they're evaluating this intervention, and some of them might report the detail and it's clear that actually they're quite different. Some of them might not report the detail. So I think there's more, as things are progressing, there's more guidelines for reporting that detail and using ontologies in behavioural science, and we need to use that throughout so that in the evaluation part we can kind of make sure that we're consistent. That will help with model reuse, and it will help with kind of understanding for policymakers exactly what we're evaluating. And then step D is behavioural systems mapping, and I'll go through a case study on smoking cessation at the end, which will go into that in more detail. But this is kind of about defining the theory, understanding what we're trying to achieve, before then part 2, which is about developing and justifying the model structure. So in some cases, these things won't always be feasible. So there's a number of questions about the characteristics of the behaviour of interest. And there's some questions about the type of question being assessed within the model. And there's an answer of yes or no, and then that will suggest various methods. And then you can click on those methods to find out more about them. In some cases, it will say build an agent-based model. That would be the most appropriate, and you've got 3 months, and so probably you're not going to be able to do that. So, but then it's about kind of being, it provides kind of a transparent process for justifying what you're doing and why you're not doing what you're doing, why you're not going to build an agent-based model, and what the implications might be of that. So it's kind of, once you've gone through the kind of understanding of the problem bit, you can understand what is needed and then work out what's practically possible. And so I won't go through all of these, but there are questions like, are 2 or more types of behaviours likely to influence each other so that they will affect outcomes of interest more than the simple addition of outcomes associated with each behaviour? So for example, smoking and alcohol consumption. And then if the answer to that is no, then you'd move on to the next question. If the answer is yes, then you'd look at if there's individual level data, which is preferably longitudinal and spatial, with the relevant behavioural outcomes reported, or could these data be collected? And if so, then you might want to do some econometric analyses. And so I'll kind of skip to the and well, I'll show you a question under the type of question being assessed within the model. So then there's questions about like what the decision makers want. So do decision makers want to assess the impact of increasing access to place, so the built or natural environment? And is the data showing an interaction between access to place and behaviour, or could this data be collected? If the answer is yes, then it might make sense to do some geographical information system analysis alongside an ABM, or within an ABM. So there's kind of a number of questions like that which link to the methods, which might be most appropriate in each of those circumstances. And then there's a set, so you can then click on each of the methods and learn more about them. And then there's a method summary table. And this summarises all 12 methods included by saying what the method is, when and why you would use it, how can the method and approach bring behavioural influences into the model, and which minimum data or input are required. And then it gives some key references to kind of follow up and understand the method more. And as I said, this kind of summary table is then expanded upon in the written parts of each of the pages on here. So that's kind of a summary of it. So it includes, so I've talked through the first four. It also includes agent-based modelling, differential equation modelling, social network analysis, geographical information system analysis to incorporate into an ABM, discrete event simulation, theory-informed statistical and econometric analyses, expert elicitation, so they're not, expert elicitation and qualitative research and process tracing. So they're not all necessarily quantitative, but they could, so qualitative research could feed into a quantitative model. So it's all methods that might be useful in that way. And so each of these you can click on and understand more about them. We've had a discussion about kind of what is a model. So in here we've got a set of different models. We've got conceptual modelling, so we're using behavioural systems mapping, so not actually the quantified model, but the theory. And then we've got computer-based models like agent-based modelling, differential equation modelling. And then we've got more statistical models, so theory-informed statistical and econometric analyses. So there's kind of different types of model within this, but all of those types of model will kind of think about how an input might change an output. That's the kind of overarching definition, I would say. So from that, so within this work, we developed some recommendations for further research. And these are really important because there's quite a few things arising that at this point we actually need to develop further. And one of the things was to develop collaborations between health economic modellers and behavioural and social scientists. But some of the recommendations related to, as I was saying before, kind of it was a two-way thing to kind of the behavioural science side. So there are lots of behavioural theories available, but some of them have been shown not to be valid for predicting behaviour. Some of them are not kind of comprehensive, and there's not really a consensus about which behavioural theories to use. So the kind of recommendation is to develop, which makes it difficult for kind of modelers to pick up and use because there's a lot to kind of think through there. So one of the recommendations is to develop a consensus statement on the most appropriate behavioural theories for each health-related behaviour. And then to develop a suite of public health economic agent-based models, which are built flexibly and reported open source to allow model reuse and adaptation. So one of the issues is that these complex systems models like agent-based models do take quite a lot of development, and I think we're now getting better at kind of making things open source, but to build them in modular ways so that they can be kind of added on and adapted. And then another recommendation is to develop and evaluate methods for informing long-term assumptions about intervention effectiveness, including using expert panels, elicitation approaches, and GP records. And to train modelers to utilise new methods via short courses, webcasts, and workshops. So I think we've got quite a range of kind of disciplines here, and some people might be really like familiar with agent-based models or system dynamics. In health economics, the majority of people are building like cohort Markov models or micro simulations, and maybe some people might build discrete event simulations, but we kind of haven't use much in the way of complex systems models, or not many modelers have. So there's a need there for training modelers to be able to use these methods. So I'm just going to go through a smoking cessation case study example. And it focuses on the behavioural systems mapping element, but it does kind of look at all of these things. But the reason it focuses on that is because agent-based models are very well established in terms of kind of, you know, computationally what you do, and same with system dynamics and discrete event simulation. But actually, kind of the process by which you might incorporate behavioural theory into these things conceptually is less well developed. And when we've included in the toolbox behavioural systems maps, actually that's not really well defined or been done a lot. So it's a very new method, and so we wanted to explore that a bit further. So I just wanted to go through the kind of basic smoking model that we kind of base this states on. So we've got a never smoker, that you might progress to being a smoker, you might then go to become a new quitter, and then you might progress to being an ongoing quitter. And there's a number of what we call tunnel states if we're building a Markov model, which so this is the agent-based model that we eventually developed, works on a monthly tick. And so each month you might remain a quitter, or you might relapse to be a smoker. And the reason for having a new quitter and then ongoing quitter is because the probability of relapsing changes according to how long you've been quit for. So we need different states to model that. And obviously the longer you've been quit for, it also affects your outcomes, the probability of having negative health outcomes. So you then might become an ex-smoker, and then at any of these points you might relapse to becoming a smoker again. So typically we would have a probability for each of the arrows on here, each of these possible transitions. So within a cohort Markov model or a traditional microsimulation, we'd have just a probability of becoming a smoker and a probability of quitting. But what we want to do is to be able to incorporate some behavioural theory within this to understand the influences on these a little bit more. And we chose to focus on the probability of quit and the probability of maintaining the quit. And the reason for that is because the policy of interest was smoking cessation. So if we were looking at how to stop people from starting to smoke in the first place, which we may progress on to, we would also need to look at this probability in more detail. But for the moment, we're using just a standard probability of progressing to being a smoker and a standard probability of relapse. But we're trying to uncover the probability of quit attempts and maintenance of the quit, looking at the influences on behaviour. And we're doing that with the PHEM-B model of behaviour. I've used the word model there, but I prefer framework to avoid confusion of the term model. But it's the idea, you introduced it very briefly in your talk, and because some of these theories are not necessarily comprehensive, the idea of the PHEM-B model is that this is a comprehensive framework to describe behaviour, so through capability, motivation and opportunity. And this was a collaboration with UCL. One of the people was Robert West, who was involved in developing this framework. What you can do is to incorporate theory within this framework. So we often can't observe capability, motivation, and opportunity directly, but there might be things that we can measure, which we can use to represent these things. So we wanted to, first of all, identify the behaviours of interest that we would be looking at in terms of the influences on behaviour. So these were quit attempt and quit maintenance. This bit, I only go through in detail the quit attempt just because of time, but we do a very similar thing for quit maintenance. So you can see that we've got tobacco smoking quit attempts in the blue oval, and then there's an opportunity, motivation, and capability, which links to this. And this can be represented within the framework in different ways. So you can see that capability and opportunity link into motivation, which then goes into quit attempt. In our maintenance map, opportunity and capability go directly into the behaviour, and that's according to whatever is appropriate for that particular behaviour based on the expertise of the behavioural scientists. And for each of these, you notice that it's composite, so this is made up of a combination of different factors. So just zooming into the opportunity, the composite opportunity. So we've called the composite opportunity, motivation, and capability level 1 variables, and then we've got some level 2 variables which link into these. So living in social housing, the level of interaction with smokers in the social network, the level of exposure to smoking cessation prompts and triggers, and the prevalence of smoking in the geographical locality were thought to affect the opportunity to quit. And this was based on so a lot of the kind of data that we, so the behavioural scientists that we work with at UCL have been developing a smoking toolkit study, which uses a large sample in England of people where they ask some of these questions. So they have done quite a lot of analysis of this data. And so it's based on kind of that analysis as well as other literature which might look at the relationships and the expertise of the behavioural scientists that we're working with to kind of choose the variables that link into opportunity. And you can see that some of these are red arrows and some are blue. So for the red means that an increase in the variable leads to a decrease in the opportunity. So an increase in the level of interaction with smokers in the social network will lead to a decrease in the opportunity to quit. Whereas a blue arrow means that an increase in the variable leads to an increase in the opportunity. So an increase in the level of exposure to smoking cessation prompts and triggers leads to an increase in composite opportunity to quit. And so we do this with each, and the idea of this is to kind of develop that theory before before building the model and kind of having a very clear theory set out of how the interventions might work. So for capability, there's level of understanding of smoking harms and self-efficacy for quitting smoking, which affects capability. And for motivation, we have level of spending on cigarettes, strength of intention and desire to quit, level of enjoyment of smoking, positive smoker identity, use of NIT, age, and number of recent quit attempts. And they all kind of feed into composite motivation to quit smoking. And you can see that there's a feedback loop here. So if somebody quits smoking, it's not actually quite a standard feedback loop because it's kind of logical rather than causal. So if somebody quits, the number of recent quit attempts increases, and this is going to increase their motivation to quit next time. So that's a positive feedback loop there. And then if they do quit, then they move on to the quit maintenance behavioural systems map. And then so if we increase age, we have a reduced motivation to quit. That's a very good question, but there is evidence to suggest that kind of older age groups are more reluctant to quit. I suppose it's because like they're the ones that have really stuck at it through all the campaigns, through all, you know, the kind of have got the still smoking. So the kind of, there might be less people in that category, but they're less, the ones that are smoking are less likely to quit. And then we've got so we've got our behaviour, we've got our level 1 variables, we've got our level 2 variables, which I've removed a lot of them here, just so that the screen isn't too full, so that you can read everything. But then we incorporate our potential interventions. So in this case, we've got a mass media campaign, and we want to say what that links to in terms of the level 2 variables. So I've just kept the level 2 variables that theoretically the mass media campaign will affect. So this is based on evidence of mass media campaigns, and how the theory of how they will work. So the theory is that they'll affect the level of exposure to smoking cessation prompts and triggers, strength of intention and desire to quit, and the level of understanding of smoking harms. Oh, so we can do this for all the potential interventions. And then we also include macro level variables, so things in the environment that might affect our level 2 variables, or be affected by our interventions. So we chose to develop e-cigarette use as a macro level variable. So we do have e-cigarette use as a level 2 variable in our maintenance model, so the macro level will affect the individual e-cigarette use. We could have looked at the influences on e-cigarette use in the same way as we have done with smoking, but this wasn't a model to look at vaping policies. So for the kind of first version of the model, we're just kind of using a market diffusion curve, which will then give people, either people will use e-cigarettes or not. And then we have a social network. So we simulate a social network of smokers and vapors, and with different ages and sex and IMD. And then their social network will affect the level of interaction with smokers in their social network, which will affect their opportunity and motivation to quit. And so if somebody quits, there'll be less people in the social network that smoke, and that will affect somebody else's level of interaction with smokers in their social network, which will then affect the opportunity and motivation to quit. So you can see that kind of feedback loop over time might mean that the number of smokers could decrease because there's less smokers in the networks, which makes quitting smoking easier. So then eventually kind of social norms change. So that could produce kind of a step change in what happens. And then we have a number of other macro level variables, including pricing of cigarettes, other tobacco products and e-cigarettes, and supply side action from industry. So this is the whole map, which I'm not expecting us to be able to read, but it kind of follows what we've said. So this is the theory-based quit attempts behavioural systems map. And you can see that a lot of it operates through motivation, and there's some through opportunity. There's much less through capability to quit initially. But then our quit maintenance behavioural systems map, which was developed in the same way, you can see that actually most things work through capability. So there's only one variable, non-smoker self-identity, that affects motivation. And actually there's a feedback loop there. So if you have a non-smoker self-identity, and that, then you have more motivation to maintain the quit. And if you maintain the quit, then that increases your non-smoker self-identity, and so on. So that kind of means that the longer you have quit, the more likely you are to maintain the quit. But that's the only variable that links to motivation, and there are a lot that links to capability. So what that's saying is that there's different influences for smoking quit to smoking quit maintenance, which means that you might want to have different policies to do those things. And actually, if you kind of look at a combination of policies within the agent-based model that this then feeds into, you can look at a policy that might affect your quit maintenance, alongside a policy that might affect your quit attempts more. There are kind of a couple of other feedback loops. So the cigarette addiction strength. So the longer you have, if you maintain your quits, then you are more likely to reduce your cigarette addiction strength, which means that you're then more likely to have the capability to maintain the quit. And so these are, so we kind of developed these over quite a long time. We had kind of regular meetings with the behavioural science colleagues who, so we used data and their input to think about these, and they really kind of helped. Like the behavioural scientists said, they wouldn't have thought about things in a certain way without this, which was quite interesting. And we tried to set out a bit of a kind of method for doing this that could be followed in other projects. So identifying the key behavioural states to be modelled, link important individual and macro level factors to behaviour using behavioural theory, and that's the theory-based behavioural systems map. And then incorporate the mechanisms of action of the policies according to evidence, and then to identify what is feasible to be modelled, the most appropriate approach for quantifying relationships and document excluded variables. And that produces database behavioural systems maps. So I haven't actually presented the database behavioural systems maps because I didn't want to throw too many things in the time that we had. But in this case, we actually had data for pretty much all of these variables because the Smoking Toolkit study is such a good resource. And we supplemented that with like the Health Survey for England, and that allowed us to be able to kind of model most of this. But if that wasn't the case, then you would need to either combine lots of data sets, which we're doing in a different project, to be able to kind of incorporate all these, do some sort of elicitation if a variable was really important, or it might be that you need to exclude one of the kind of variables that in theory you'd want to include, but then kind of clearly document that as to like the difference between the theory and what you've actually modelled. And this is all a collaboration between decision modelers and behavioural scientists. And alongside this, developing the behavioural systems maps, we developed a data dictionary to record all the variables. And we also recorded all ontological IDs for every single variable that was in here. So for all of these variables, there's an ontological ID so that we can kind of, so that it's very clear as to what's in the model. And we also included what data was available and how they'd be represented in the model. So what the measures are, what the bounds of the measure are, whether they're dynamic or static. So we had kind of a data dictionary that sets all this out. And then, which included all of these things. And obviously the variables that are in the data dictionary are dependent upon what variables are in here. And then from this, we could do some, so we developed a synthetic population. And so the synthetic population was based on the Health Survey for England and the Smoking Toolkit study. And we utilised all the variables here. So every person in the model had a kind of value for each of these variables, which might either be static or change over time. And we also developed a social network. So we had to add in a question to the Smoking Toolkit study survey, several questions, to understand kind of the relationship with other people and whether they smoked and their age and things like that. So we kind of developed a set of questions which allowed us to then be able to simulate a synthetic network of people so that then we could update how many people smoked according to whether or not they quit or maintain the quit, and how that then affected the behaviour of the people in the model. And then we did some statistical analysis which kind of allowed us to calculate so based upon the kind of data that we have for all of the level 2 variables, it then allowed us to make predictions about composite capability and whether or not you quit and maintain the quit. And then these were used as priors within the agent-based model, and then we're currently calibrating the agent-based model against existing data on these probabilities, so that as we were kind of discussing before about kind of these variables being often self-reported, and they've been not being kind of perfect, by using them as priors, it kind of provides a starting point for the calibration, but it does mean that they can be modified according to how much they affect the probability of quit and maintenance of the quit. And then the plan next is to, once we've finished the calibration process, we've got kind of 3 periods of data. So for the first 2 periods, it's used for the calibration. For the last period, that will be used for validation, to check that it kind of then the calibrated estimates then predict what we would expect. And then we'll kind of predict forward from there using this theory. So from this case study, we thought that behavioural systems mapping provides a systematic and transparent framework for incorporating behavioural theory and empirical data into simulation policy models, and hopefully addresses some of the things that we talked about in the first talk. The system's maps acted as boundary objects, enabling multidisciplinary discussions about the relationships in the model structure. And there are distinct mechanisms for smoking quit attempt and smoking quit maintenance, which without doing this you wouldn't incorporate. So you just have a very simple model, which might not get to this, and then you might make quite uninformed predictions about the impact of policies. The development of 5 feedback loops, where the behaviour affects the values of the individual variables which affect the behaviour, allows population level behaviour, which is difficult to predict, to emerge once quantified. And using this framework to develop a simulation model should lead to more informed predictions about policy impacts, including the effects on different subgroups. So we're just finalising version 1 of the smoking cessation ABM. And we've also used the PHEM-B toolbox for designing a vaping health economic model, but we haven't actually developed the model yet. And actually what we're going to do first there is to develop not an agent-based model, but a standard micro simulation model first, which can then be modified into an agent-based model next, due to kind of data limitations and things. So I think you can still do kind of the kind of conceptual modelling without necessarily following it through with the most complex modelling approach if it's not feasible. We're currently developing an ABM model of place-based food policies and their interaction with food insecurity using these methods. And we're also using these methods for the development of a gambling harms prevention model. So we're trying to kind of develop a set of models using this.